pressure of oxygen was 34.2 mmHg and CO2 was 46.5 mmHg. After intubating, the PO2 level increased to 120 mmHg and 198 mmHg. These were the trends of ABG of the same day. The X-ray showed EP tube tip that appears in the mid-tracheal region, and secretions were seen in both the lungs, predominantly in the lower zone, and it appears as patchy opacities. On inspection, we found that there was paradoxical movement of the lungs, and on auscultation, retained secretions can be heard. So, our diagnosis was respiratory failure type 1, and which was led due to ketoacidosis. So, TKA is basically a life-threatening complication of diabetes, and which can lead to type 1 respiratory failure because of metabolic acidosis. And because of metabolic acidosis, patients compensate that acidosis with breathing in personal breathing pattern, which leads to low PCO2, which is respiratory alkalosis. So basically, due to TKA, patient went into metabolic acidosis because of increased ketones, and with that compensatory hyperventilation occurs, which basically which can lead to either pulmonary edema or acute respiratory distress syndrome, or even pneumonitis or pneumonia, which again can lead to decrease in the oxygen pressure and decrease or normal PCO2 value. This is the main same mechanism which is described, that it can either lead to pulmonary edema, ARDS, pneumonitis, or electrolyte imbalance. So basic goals of the physiotherapy was to improve oxygenation by positioning like upright or prone in ICU to enhance lung expansion, and breathing exercise to optimize alveolar ventilation. Second was to clear the airway secretion. It was done by physiotherapy techniques like percussion, vibration, and postural drainage, and ACDT, puffing and puffing. Third one was to promote lung expansion by incentive spirometry and deep breathing exercises. Further, our goals were to prevent deconditioning by early mobilization to improve cardiopulmonary function and to prevent complications of mobility, to enhance functional independence by functional training and respiratory muscle training, and to educate patients by doing different conservative techniques. Thank you.
Dr. Fallure, myself Anshipa Attray, MPT student. I will be presenting here the physiotherapy management of a 45-year-old female, which is type 1 respiratory failure. The physiotherapy management here focuses on mainly improving the oxygenation, gas exchange, and which involves many techniques like clear secretion, enhanced lungs expansion, optimized breathing patterns. The interventions include here are airway clearance techniques, breathing exercises, and positioning strategies. Phase 1, when the patient is on ventilator mode, part A, the mode is VC mode, that is volume control mode. Here we have done the passive physiotherapy exercises showing chest physiotherapy, in which we have NPF technique. The subpart of the NPF technique which we done on the patient was moderate manual pressure, intercostal stretch, mechanical vibrations, percussions, followed with the limb physiotherapy, that is ATMs. Here you can see that PRN with the 5 repetitions only, and the patient is having only passive exercises. We are doing only passive exercises, that is PRN. Knee bending response with 5 repetitions, moderate manual pressure. When the patient is in the lying position, the lung zone which is affected, we manually give a moderate pressure on the lung area which is affected, so that the lung expansion is there, and the intercostal stretch, the outer layer of the rib is we give pressure on the outer layer of the rib so that there is a stretch, expansion on the ribs. The air entry can be increased. Phase 1, the patient is still on the ventilator. The mode is changed to the CPAP mode. Chest physiotherapy given to the patient was the same. NPF technique, mechanical vibrations, pulsation, but the limb physiotherapy has been progressively changed to ATMs with AARO active assisted range of motions with 10 repetitions, knee bending, wrist pumps. Phase 2, after weaning off the patient, the chest physiotherapy has changed to NPF. One more technique is added here, the perioral pressure. Along with the 2 moderate manual pressure, intercostal stretch. Diaphragmatic breathing with 10 repetitions, segmental breathing, thoracic expansion, percussions, mechanical vibration, huffing, puffing, and spirometry is also added because the patient is now active with the ICEC values 600 cc each. Firstly, breathing with 10 repetitions, breathing with 10 repetitions. Here there is a new technique. Perioral pressure is done on the patient, in which the therapist's finger is kept on the upper lip, between the lip and nose, and there is pressure is created by the therapist in duration which he desires or she desires, which gives a reflexive, primitive reflex in which the patient urges to deep breathe. These are the pictures showing thoracic expansion by the patient, in which you can see the patient is comparatively active as she was on ventilator mode. Incentive spirometry was done. Limb physiotherapy progressively changed to AROM, that is active range of motion with 15 repetitions each. Comparing the chest X-rays here of dates, that is 25th, 2nd, 7th. There is you can see on the 25th of June, the chest X-ray shows the bilateral dense lung obesity, reduced lung volume. While on 2nd July, bilateral dense, especially in right lower lung, CP angle is blunt, right, majorly in right, then in left. And on 7th of July, lung fields are comparatively clear. CP angle is more clear than other days before. Current status of patient is now that patient is shifted to MIC4 from GICU and maintaining SpO2 greater than 90% in room air. Activity status is like bedside sitting has started, chair sitting has started, and the patient is more oriented than before. Patient doing thoracic expansion, as you can see, actively following the commands. These are the variations and vitals from day 1 till today. 23rd June on volume control mode, the vitals were 167 per minute pulse. Respiratory rate 22 per minute, blood pressure 90 by 50 mmHg, SpO2 95%. On 29th June, you can see on CPAP mode, the vitals are progressively changed. And on 9th of July, that means today, on room air, the patient was maintaining the SpO2 of 99% without any oxygen support, with a respiratory rate of 20 per minute.
Thank you so much, Dr. Anshipa, for explaining us the physiotherapeutic management of respiratory failure patients.